On behalf of FACEMI, Families Alliance on Mental Illness, I warmly welcome each one of you and all our special guests who have taken time to join us for today's webinar, The Golden Hour in Psychiatry. FACEMI was founded by Dr. Nirmala Srinivasan with a vision to advocate for the rights and wellness of families and their loved ones living with mental illness. Over the years, FACEMI has grown into a national collective with 4 zones: Maitri Bangalore, Shanti Delhi, Shakti Kolkata, and Family Mumbai. I'll be sharing the contact details in the chat during the session for anyone who would like to contact with us further. One of our work with various state government has been advocating for psychiatric emergencies, response systems, which is the ambulance services during psychiatric services. And this year, the World Mental Health Day 2025 theme is Access to Services, Mental Health in Catastrophes and Emergencies. So in observance of the World Mental Health Day theme, which is similar to the work which we've been doing, FACEMI launched a conversation series on the Golden Hour in Psychiatry. In series 1, we had an enriching discussion with Dr. Rajni from Government of Karnataka, Dr. Krishna Prasad from NIMHANS, and Sumit Guha, who shared his lived experience perspective. To take this important dialogue forward, we now begin our series 2. And our moderator for today is Mr. Anmol Tiku, an educator and facilitator who has designed and taught courses on cinema, philosophy, identity, environment, development, and globalization. He's also a filmmaker and a writer, which adds depth to his approach. With that, it's my pleasure to hand it over to Anmol to take this forward. Over to you, Anmol.
Thanks a lot for that very, very generous introduction, Saraswati. I hope I am audible and clear because I know there's some noise in my background that suddenly started. Hopefully it'll go away soon. It's a privilege for me to be here with this really power-packed panel, and I hope everyone who's joining us is in for illuminating, enlightening conversation and a productive conversation that will help us build on the mental health that needs to happen in the country. I think it's amazing that we have with us Dr. Nirmala Srinivasan, who is a sociologist and who's also who's who's a leading mental health advocate, who's been in this SHA, who's a psychiatrist and an HOD of the psychiatry department at the BGS Hospital in Bangalore. We have Dr. Nishant, who is the assistant professor at NIMHANS with us. And we have Mr. Vijay Nalavala, who is also a longtime advocate, an author, and a founder of the Mental Health Foundation, Bipolar India, and Let's Walk Together programs. So we have a good mix of people who are working in policy, people who are working, as clinicians and with institutions to support better mental health outcomes, and also people who have families and personal experience of interfacing with the mental health crises and institutions of this country. So very, very excited for this conversation. And if it's not too presumptuous, I'll just start off by saying that actually, besides working in the mental health space, I think all our panelists might actually have a common ground in that we want mental health to be taken as we take physical health, right? And I think I was reading studies. Where psychiatrists report that they face from other medical professions, right? Like that psychiatry is not considered a hard science and a medical profession as other maybe medical professions, right? And that's that there's a stigma there itself and an othering. There's obviously the experience of people who have with mental health institutions as users, as families, and there's also as policymakers, people who are trying to attend to mental health as seriously, the government is willing to kind of today is so. Without much ado, I wanted to just kind of take this moment to say that today, in trying to kind of bring mental health at parity with physical health, I think one of our attempts today is to actually look at what is called the golden hour in terms to physical trauma and physical health related emergencies. We are trying to look at golden hour as it relates to mental health and psychiatric crisis. How do we work together to get the same kind of care, the same kind of attention, and the same kind of quest for better outcomes for mental health crises, mental illness related crises. So I'm hoping that with this topic we can have a productive conversation together. What we'll do is we'll start off with Dr. Dr. Nirmala Srinivasan, then move to Dr. Virupaksha, and then go to Mr. Vijay Nallawala, and then finally get to Mr. Dr. Nishant so that we can get some opening remarks from each one of them. And then after that, we'll have a kind of a response to each other's kind of opening remarks. Does that make sense? Is that okay with all our panelists?
Yeah.
Okay, great, fantastic. So, uh, Nirmala, if I may just take a first name basis, could you please kind of share your understanding of what is this golden hour for psychiatry and psychiatric crisis? What does it mean for you? And why did you and the families that you've been engaging with find a need for this golden hour?
Thanks, Anmol. And you have set the most appropriate and positive note for this entire panel discussion by highlighting the parity of psychiatric emergencies with physical emergencies. Yes, that is our biggest concern. And it's also an important challenge for many of the doctors because currently mental health is getting integrated into public health. And therefore, it is time that these things are not looked at as standalone challenges, either by the families or by the psychiatrists. That's very important. Thank you so much for that appropriate note to start the panel discussion. Moving on, golden hour is not a buzzword in psychiatry. We hear ECTs and CBTs, but not golden hour very often. We don't even hear among NGOs talking about it. It's very rarely done. So, as Anmol, our moderator said, you will all be wondering why we hit upon this concept. Our advocacy, this is how it all started about a month back. Our advocacy for the 108 public health free ambulance services. As I said, mental health has got integrated into public health, and therefore the entitlement of free ambulance services for psychiatric patients is already there, and it is also supported by the Mental Health Care Act, which has a special section on emergencies, rights of the people, rights of the persons with mental illness to psychiatric emergencies. So the advocacy with the governments, we were negotiation and we were trying to get to see what is happening across India. You will all be surprised to hear that in some places there are no ambulance at all. They are not even aware. When I say they, I mean that the state government level, the officials are definitely aware of the Mental Health Care Act, but have not gone into such details that they should have a ambulance under public health. And some places, ambulance 108 is there. It is also shifting the patients, but not appropriately in the way the physical emergencies are taken care of. So when all these things happen, what is the interest for us? The entire data we collected in ambulance is spawned by challenges faced by families across India. It's not just based on our meetings with the officials, but also this matched with the stories. And I mean, it's not right to call them stories, they're experiences, they're challenges, they're problems, crises in families across India. So then it was a big revelation to us that there is no such thing as first aid in psychiatry happening, while first aid is being administered to the victims of physical ailments and accidents. That came as that was a stark revelation we had from all these things. So that is how this entire discussion started, and we were thinking what is happening. And as Saraswati pointed out, the World Mental Health Day theme coincided with this, and we struck upon the golden hour in psychiatry just to see how exactly this concept can be elaborated further, especially by the two experts here, Dr. Nishant and the psychiatrist here, because after all, we don't want to dismiss the medical aspects of it, because the medical aspect is a very core of the first aid to be given. But apart from the medical, what other aspects can we explore? This is exactly what I'm trying to say in my presentation. Can I have the transparency, Saraswati or Anmol? I don't know. Saraswati, Anmol, can I have my PPT or shall I share it?
Yes, yes. No,
Yes.
I'll share it. One second.
Okay. Not only a question of getting an ambulance, but getting it on time. Ambulance means getting it on time. Getting the it's a combination of many factors, not just a vehicle coming and parking in the front of the house. For psychiatric patient, that is what we are going to explore. And yes, Anmol, I can also share it.
I'll share it. Just give me.
Okay. He's also trying. I hope it won't be a clash. So my presentation is from the user's perspective. So the title, this is the only PPT I have. I thought it's easy for me to explain because it's a topic which there's nothing much to talk about, but we have tried to generate what we can talk about on this concept and to provide clarity for further action on this. So golden hour in psychiatry from user perspectives, user here is families and the person with mental illness. So you can see two sides of the PPT here. On one side is the needs based. It's all here on this side. I'm showing the cursor there. Let's look at this first. The need based is what is currently happening in psychiatry, and that is golden hour is now currently happening in post-traumatic stress disorders, attempted self-harm, as well as in involuntary admissions, occasional involuntary admissions of persons with mental illness. In other words, if you actually look at it, the first two categories are not necessarily exclusively for the PMIs. It's also for others, general public, people who have experienced traumatic situations, episodes, who may or may not rush to help immediately, because some of these traumatic situations and stress disorders can surface after several years. And what we see mostly, something happens in childhood and surfaces after adulthood or midlife crisis. So these are not necessarily golden hour, but all said and done, 2013 was the first 2013 marks the year when the psychiatric manual of operations called DSM defined psychological first aid as a tool for handling post-traumatic stress disorder. So psychological first aid was a tool, which means, I assume, when they say psychological, there was no golden hour as such. It was not 60 minutes or 90 minutes, to not encapsulated in any time slot, but depending on the needs, each case may have a different need depending on the differential needs of the various victims. You have gone the trauma victims, it was administered, and that was defined. So psychological first aid was the definition given in psychiatry in 2013. Probably the doctors here can elaborate on this better, but this is the manual I could lay hands on, the first definition of golden hour. Golden hour is nothing but a psychological tool, and in fact, DSM goes to the extent of saying golden hour in psychiatry is different to golden hour in other physical illnesses and ailments. So that is the definition we see here. And then, of course, attempted self-harm. I don't want to really call it suicide alone, because there are many different types of attempted self-harm, and it includes suicide cases, attempted cases. And here you all know, obviously, the person is rushed to the facility immediately. If there are people come to know about it, it all again depends. And then one important and very commendable thing is the Government of India in the Mental Health Care Act has decriminalized suicide, and that has helped in reinforcing the psychological first aid rather than the police inquiry. So attempted suicides and self-harm cases are no longer rushed to police stations. It's a very big improvement, progress. Once again, it's not 1 hour or 2 hours. This is what you should know. This helps a lot to understand the implications of golden hour in psychiatry later at the end of the panel, if we can understand. It's not here time limit, like they say for the first hour is important for cardiac patients, first hour is important for stroke patients. It's not like this. After several years, some of us can report either a traumatic incident or an attempted self-harm and things like that. So these are generally for both PMIs and other general public, whereas involuntary admissions here refers exclusively to the PMIs who are unwilling, who have had a relapse, who are going through certain emergencies, may not have had a relapse, but still who are not happy, who are not functional, who are not able to carry on the obligations day-to-day life or their own, whatever they have, either as in the college or in the office, whatever it is, the workplace problems and challenges. So they are not able to, no coping skills possible. And such cases who need admissions sometimes have found it very difficult to be accepted by the facilities. Many cases of involuntary admissions have been refused by the hospitals and psychiatric nursing homes, not necessarily by government facilities, but there are instances in our groups, in FACEMI, where family members who have taken their patients coming under the involuntary admissions category to government facilities have been told, no, we don't handle such cases. Now, the biggest problem within quotes faced by psychiatrists, I'm told, is here the golden hour is defined legally in the Mental Health Care Act as 72 hours, beyond which the treating doctor has to report to the Mental Health Review Board if they have to continue with the treatment and send a report accordingly. So because 72 hours, many doctors fear may not be adequate to treat the emergencies. The cases have been refused, which is a big challenge to many families, because once the treatment, it's a very traumatic experience by itself. It's a challenge to take the patient to the doctor, and on top of it, if it's refused admission on grounds of not being able to handle such cases, especially in hospitals where there are psychiatric inpatient admissions. I can understand these cases don't go to the OPD clinics run by many doctors, but they go to nursing homes or hospitals, maybe general hospitals with psychiatric admissions, or specifically exclusively for psychiatric patients. But cases of having refused for admission are not uncommon. This is a very sad thing. We can talk about it. But here, the golden hour as defined by law, I don't know, but this is not defined by any DSM or something. The rights-based law, Mental Health Care Act, defines 72 hours necessary for treatment of a psychiatric patient. Now, this is, I need my transparency. Can I share it? I'll share it. Just a minute, please.
I can share it, Madam
So
Rama.
please
Would you
do.
like others to move on and talk?
You can share it. Otherwise, I may thread.
Yeah, and Nirmala, if you can just take the next 1 minute to wrap up, because then we're able to actually carry on. Yeah.
I have to say the most important thing. I've not yet come to that. Please give me 2 minutes. But I need my transparency. Saraswati, can you show it? I'll go through it very fast. You are okay. Sorry, folks. So we are coming. This is currently happening. What we are asking for is, please look at golden hours, expand it. If I can use the word Viksit, which is very common these days, can we have Viksit psychiatry? Can we have rights-based golden hours as first aid in emergencies, which is principles of equity, justice, and equality, as endorsed, as provided for in the Mental Health Care Act. Right now, Government of Karnataka probably has embarked on this, giving first aid medication. When I say first aid, it's medication, proper psychiatric medication, either haloperidol or ketamine injections in the ambulance while the patient is being shifted. This probably is not done in public health ambulances across India. As I said, ambulance centrals are not there. Involuntary admissions, I've already told, but involuntary admissions, we have to be treated at par with accident victims. Accident victims have the Motor Vehicles Act, Good Samaritans Act, Cashless Treatment Act, so many things, so that they cannot be refused, they cannot be rejected. Admission is mandatory. They cannot be. Otherwise, the license of the health facility will be cancelled. I wish something like that has to happen for involuntary admissions of patients, psychiatric patients as well, at par with accident victims. Finally, this is a little elaborate thing. Golden hour in psychiatry can happen, should happen even at stages of early intervention, follow of dropouts from treatment. We are not going to miss that important golden hour that we are missing currently happening, which is culminating in the alarming treatment gap of 92%, because the largest number of untreated, the largest bulk of untreated people live in families, and assisted home care is a very important scheme or program to be run, so that the golden hour of catching these untreated people, which is not happening even in Telemanas. We can discuss this, which can be taken care of under the treatment of the treating psychiatrists or the team in various districts and DMHP clinics. Golden hour must be looked upon even at the assisted home care facility to cover early intervention and other fall dropout cases. Thank you so much. We can discuss this later if we get time. Thank you so much. Sorry if I've taken a minute or more so.
Thank you, Nirmala. Building on what you were just saying about this more expanded or more fleshed out version of Golden Hour for Psychiatry, I want to move on to Dr. Virupaksha. And given his decades of experience of treating patients who come to him in psychiatric emergencies and crises, what do you actually find in terms of gaps in the time to treatment, effective, appropriate treatment? And what do you see as essential components for a golden hour for psychiatry that would actually positively affect patient outcomes in the long run?
Yeah, thanks Anmol, and thanks Dr. Nirmala Srinivasan for providing that very important, I think, structure for the further discussion today. From the perspective of a mental health professional in general and psychiatrist being specific, I think the concept of golden hour, or the initial time of treatment, has always been in great need, primarily because psychiatry is, I think Dr. Nirmala also spoke about, the lot of stigma, delay, and all those component. If I have to probably, in a very simplistic way, explain, there are multiple components which has led into the problem that we are in today, where unfortunately psychiatric disorders are not recognized early, not being treated to the extent that is required, leading into a significant amount of what we call it as disability or morbidity, which not just impairs the patient, but also the family and the society as a whole. It is not just the burden on the patient and family, it's a burden on the whole system. So I think in terms of the major component is the awareness. And what I have found through my personal experience is, not the public, within the health system itself, there is a lack of awareness about the need to recognize early and intervene. And that is one of the reason why we are in a problem where there is no ambulance system. There is no. Dr. Nirmala also mentioned about how are we not equating a physical emergency to a psychiatric emergency. And there is a small problem there. When people do not even understand that there is an emergency, unfortunately the emergency is not being given, including the family members. There is a huge uh, lag of time. To an extent, there is a lag of almost decades sometimes. And the concept that we talk in psychiatry terms is called as duration of untreated psychosis. Even though we call it as duration of untreated psychosis, it is applicable to all psychiatric disorders. One of the things that I would want to highlight is, we should not be focusing upon the golden hour, which is treatment early in just severe mental illness. It is also something that is applicable in all other psychiatric disorders also, including as simple as, people think that anxiety disorders are very minor, they are not that critical, people will recover. It is not. Sometimes it can be as disabling as schizophrenia, not removing any significance to major psychiatric disorders, but the minor psychiatric disorders are also equally important. And one of the thing probably which I can explain from my experience with other systems is, I also work for wellness center in IISc, where we have a very robust system where we have developed, where initially, even if there is a minor reporting of symptoms by any student, we create a red flag situation and immediate support is provided within the health system in the IISc or outside. And I also work for UN system, where within the UN system there is free easy access, which is completely funded and provided by the UN. So in that context, I think the it is the holistic approach by the family in recognizing the symptoms early, by the health system by encouraging the treatment early, and by the government, which will, I think this is something that I have mentioned in multiple panels. Unfortunately, sometimes the Mental Health Care Act, when it becomes too much rights based, sometimes some of the mental health professionals go into a defensive mode of practice, because some people consider that as too risky, and which is counterproductive for us to focus on golden hour. Because in golden hour, in, I think Dr. Nirmala mentioned about the physical emergencies, there we know that we can go to any extent to save the lives of a person. And there are rules, there are certain protections for the healthcare professionals. But here, within that 72 hours, if something goes wrong, or beyond 72 hours, we require, because psychiatry is something which is long term, that unfortunately that is not there. So golden hour, to probably wrap up my initial this thing, I think it is something which is very, very important. Golden hour need not be few weeks, few months, it could be few years also. in many instances. Early treatment, early recognition of treatment, which involves a lot of stakeholders, will create a significant shift in the outcome. We call it as prognosis. Prognosis can be really, really positive. There will be exceptions where we will not be able to do anything. We are looking at people whom we can help in terms of triaging. And I think the support from the government, policy, law is also equally important. I'll stop here, and probably if there are other points, we can pick it up from there.
Uh, Thanks a lot, Dr. Virupaksha. That was very crisp and clear. And thank you for giving us lots of things to kind of build on in this conversation. I want to bring Mr. Vijay Nalawala into the conversation. And I think often, India is so diverse in its locations that we like people experience even mental health infrastructure from place to place can vary. And I think while Dr. Srinivasan was talking about assisted home care, things that are actually maybe, somewhat at work in Bangalore, the experience of a place like Bombay might be very different, right? So I want to bring you in, and I have a couple of things that I want to put in the mix with you. One is we are hearing mental health in the last few years, especially with the pandemic, it's everywhere in some ways. But do you find that this growing recognition of mental health, the importance of mental health, uh, is it actually changing outcomes for persons with mental illnesses and their families, and what do you feel about this concept of golden hour in particular, especially with your experience of seeing firsthand and interacting with people in and around Bombay? It would be great if you could share your insights.
Thank you so much, Anmol. Uh, to borrow from what Dr. Virupaksha said, I look at the concept of the golden hour way beyond that narrow 72-hour window or in the immediate crisis moment. To me, the golden hour period should be looked at from onset to diagnosis and intervention. I think that can make a material difference in the outcomes, in the quality of outcomes and the quality of life the person would then thereafter live with. Yeah. And in that context, as you rightly pointed out, that the pandemic has brought in a lot of difference. And I think social media, the internet, a lot of information flow that is now available to people very easily on the tap has created a lot of awareness, especially among those who have access to these sources of information. All right. Uh, Now, one of the signs that I see, which is maybe a positive indication, but at first sight we might say that a 19-year-old member living with bipolar disorder is part of a community. So, sort of, the one indicator is that look, a person is struggling at such an early age. But one of the insights that I draw from it is that interventions, diagnosis are happening at an earlier age. This could be because of heightened awareness. Also there might be lesser, sort of a barrier in help-seeking behavior, which could be translating into this happening. So one thing is, being aware that there might be having some problem, but then taking the next step of seeking help, professional help. So again, I do not know whether data backs it because the care gap, which also Dr. Virupaksha talked about, hinted about, the massive care gap that we talk about, that 80-85% care gap. So has it really drastically changed outcomes? Unless those people can be drawn into the net, we'll be only talking about the top of the pyramid, which might be benefited from these kind of changes that we see. That is one thing that I would sort of share about. The other aspect of your question, specifically to people from Mumbai, I mean, of course, this is a very valid question. We often assume that being in such a mega metro city, uh, help to, access to help, especially in emergency situations, as we are discussing in this conversation, would be easy for families. Now, there are several obstacles that I see, which are often there is common ground, all the experiences that we encounter. One is families themselves and the indecision on their part. Sometimes it is so stigmatizing, even for families, to take that call of admitting their loved ones into a institution. The sort of a feeling that we are dumping our loved one, that might prevent them from taking that step. Second thing is lack of information about what would be the uh, affordable quality care unit in the vicinity, despite of the information flow that we are discussing here. That kind of information is not readily accessible to people. Of course, communities like ours do help in providing that kind of information, guiding people in such contexts. Apart from that, also what Dr. Nirmala Srinivasan spoke about, access to ambulances. Having decided that we admit our person to hospital, how does that translate into action? Is it so easily doable? Now the wing of FACEMI, which is in Mumbai, FACEMI have been advocating a lot for making the 108 public ambulances available for mental crisis also, which is a commendable step. All the same, we see that uh, they hold back when it comes to these kind of admissions, saying that we might not be able to handle people who are maybe aggressive or violent, and we might not be able to control them. So that defeats the entire purpose, right? If a person is docile, cooperative, and compliant, the need for hospitalization might not even arise. Yeah, so there is a contradiction that happens there. Second is the affordability factor. Most of the mental health establishments in Mumbai, maybe because of the real estate aspects that are involved, the cost of infrastructure are out of bound for most of the families mentioned. And also the third related fact to that is lack of access to health insurance. Many people who might be already be covered under health insurance policies find that their claims are rejected on flimsy grounds, or they might not be having health insurance because of having disclosed their conditions. So there are myriad aspects you can imagine that create barriers for families to take that decisive step. And as we have discussed, I mean, throughout this conversation is the more the delay in seeking help and getting the intervention in place can worsen outcomes. So yeah, that's my submission. Thank you.
Uh, Thanks a lot, Mr. Nalawala, for sharing your insights and your experience. I think you bring in a very important perspective of how getting families to recognize and actually help families in bringing their loved ones to the kind of care that they should be getting, right? That's part of this golden hour. And of course, we have many people, many families joining us. And I think these are obviously people who are plugged in, who are thinking about this, but this is very important work that also needs to happen on our ends, and also obviously at the end of the state, how do we actually close this gap between families feeling stigmatized and seeking help at the earliest. And I think this is a good place to bring in Dr. Nishant. He's sitting under the banner of Nimhans and Telemanus, and as the leading psychiatric and neuroscience institution in India, and one of the nodal authorities for pilot programs and cutting edge initiatives from the government of India in the mental health space. It'd be great to get your insights. Given what you're hearing here, what do you think are some of the initiatives that Nemens is piloting right now to kind of reduce this time to treatment? Are there any particular initiatives in the pipeline that you can share? And obviously, given what people are suggesting about their experiences and their insights, do you find that there is something that we could be doing more to build on this? So I'm bundling these questions so that you can pick and choose and kind of share your insights. Thanks.
Thank you, Mr. Anmol. Yeah, it was far too kind of you about, yes, we being a premier institute, and yes, I'm here to express the opinions and also to let you know people about what exactly how the system is doing things for what you call as a golden hour. Couple of things first before I answer your question, like what we are doing. Let me come to a couple of things that it was discussed right now. The basic premise of this golden hour, as you mentioned, as an emergency, it comes from the fact that the always a person with severe mental illness is always aggressive. That is partially true, I would say, but most of the times it is so possible that with just verbal de-escalation, most of the times people can actually they will be amenable to the suggestions or intervention by the family or the doctors, I would say. So yes, I totally understand that there is a need for some small set of population, but when you consider India, it is not a small set. It will be a very large set of population which requires a kind of an emergency service which caters when nothing works out. We are supposed to take them to emergency. We have come across with this kind of we as a community team also, we know that there is a problem here, and we need not concentrate about only the metro cities and all. India is a very vast country. There are rural population, there are rural areas, tier 2 cities and all. So one thing that WHO always advocates is the proximity of the treatment. Whenever you are talking about any psychiatric illness or mental illness, the proximity of the treatment is utmost important. So if we want to work on it, I think we are working on it to bring the treatment to the doorstep of whether it is a person who is in a rural background, whether it is a person in his urban background, through whether it is primary health centers or community health centers. We can work by increasing the human resources here. That is one thing that I would say, rather than solely depending on to take the patient through an ambulance and all those things. The other thing that I would stress upon is that we are talking about 72 hours. I know, like this is made as a check and balance for to avoid any violation of human rights and all. That is why it is in place. But let's face, in Western countries, they have something called community treatment order. It is a community treatment order is basically a court can tell the community team and the mental health professionals that, okay, this from the feedback from the mental health professionals, the court can actually tell the police that, okay, this person needs to be shifted from the home to the hospital. Okay, see, when we are talking about this kind of practices in West, and also on other side, we are talking about the human rights. There is somewhere we need to balance it out. It is we may have to think about a better suited approach to deal such a crisis. For this, we require a robust community team that can actually work in community, rather than, let's say, okay, we have to cater to that person who is in ambulance. We need to cater to the person who we have to treat the person as early as possible. Everything said and done, basically it boils down to like how robust the support system is there for the family. I would stress upon this, for the family, for the patient. This system, it should be a safety net for them. Whenever they go to the crisis, they are supposed to be helped by this community team. And unfortunately, because of the population, the kind of population we have, we still can do it with the help of the team that is available on the ground, available with the DMHP team, or it is a TMHP team, or let's say in the bigger cities, there is the same teams are available. So if I have to tell, I would tell one thing is that golden hour treatment, I definitely understand the predicament of the family member. They will require a lot of assistance when there is a crisis. They require someone to take the patient to the hospital. I definitely understand there is a need, but it doesn't have to be always, let's say, a transportation issue or something. It is always about the awareness about how to deal with a crisis, how to de-escalate whenever there is a crisis, how to access the support system that is there in the community, to access the community, that kind of a support system. Let me tell you the reality, ground reality I have seen. Let's say in the outskirts, let's say in tier 2 cities, for example, in Shumoga, there are good psychiatry hospitals, inpatients and all. You know what the people from rural area do when there is a crisis? They just 4 or 5 people actually catch hold of that person and put it in a van, and they actually bring the patient to the hospital. It is not a good sign. It is not a pleasant thing to look at. But these things do happen in the reality. It should not happen. If there is a community program that is there, or community support system of mental health professional, or a lay professional, lay counselor, if that kind of a system is available in a community, it can be taken care. I would stop here, and I would thank you for the opportunity provided to speak a bit of my mind. Thank you.
Nishant, for your remarks about this. Um, I would like to now kind of have a chance for our guests to kind of respond to each other and to pick up on some of the things. And maybe if any of the panelists, there's something on their mind that they would like to respond to or build on some of the ideas that have been kind of put out there, it'd be great. Otherwise, I'll start poking questions. Yes, Vijay, please.
Yeah. Uh, just to take up from what Dr. Nishant talked about, completely agree that not all persons, even in a health emergency, would be so overtly aggressive or difficult to manage. In fact, we have facilitated admissions, supported admissions to hospital, taking the person in a private vehicle. So that cajoling, that sort of persuasion, a gentle persuasion can be effective as well. Right. It's just the perception sometimes from the care providers, the ambulance services. The stereotypes around the severe mental illness as such, it creates that image in the mind that the person would be completely uncontrollable. Yeah. That's it. Yeah.
Vijay, if I may actually just add to that in some way, I think it's not just that the families are afraid of the person harming them, but that they are not equipped, right? And they can't be equipped because they're not professionals. It's in dealing with these situations to de-escalate. And so what ends up happening is people are frustrated, they're stressed out, and they end up actually slapping the person, roughing the person up, and then forcibly taking them. And this actually, at least in my personal experience, having kind of gone through this firsthand, it ends up breaking down a relationship which is between a person who is going to be with the PMI in the long run. You are actually creating trauma and trust deficit. This is where actually external authority can de-escalate, keep the compact together in some ways, because those people have to live together and have to build on this. So I think pushing the buck on people or like families in that way, I'm not sure how productive it is in the long run. And what is interesting, when you were sharing the experience in Bombay, and when Nirmala was talking about the case of Bangalore, now these are the big cities in India. Forget
Yeah,
about tier two, tier three rural
sure.
areas. We know that in India, the psychiatrist to population ratio is always so absurd that basically we can, if we go by that, then we should not talk about mental health altogether, because there's like one for 1 billion people, there are 10,000 or 15,000 psychiatrists. So, in that reality, what is our best foot even in densely populated cities? How are we actually setting up something that is exemplar? And I think we can be thinking about it together maybe a little bit in that way. Nirmala, please, and then I will go to Dr. Virupaksha.
Unmute yourself, Nirmala ma'am.
Is that okay?
Yeah,
Yeah.
continue.
It's really baffling to me how this question of first aid given for shifting the patient, whether rural or urban, it's immaterial. Psychiatric patient, how it didn't happen in the practice of psychiatry and why it didn't happen. What is the reason? Why didn't it's so? If the patient a psychiatric emergency on the streets, I don't know. I'm sorry, doctors here may not have had the opportunity to having witnessed those instances. There are patients here who have run away, the whole family chasing, crossing the road, going along, autos and these things, crossing signals because they are scared of ambulance. Ambulance turns back and goes back because they are scared of the patient and the litigation. Simple thing like haloperidol, ketamine injections, which could have been given. Even now, a place like NIMANS, which is an advisory body to the ministry or government of India, just one, it may take not more than 24 hours or 48 hours for this to be communicated. Why can't the ambulance, public health ambulance, I'm not talking about private facilities. We can go to private facilities later, but we cannot talk about private facilities. Also, it may be done, but public health, why is it not? So it's my first request to Dr. Nishant. Can you kindly see to it first aid is being given? And I'm very happy to say Dr. Rajani is unfortunately not here. To some extent, we have succeeded. We means FACEMI India with Government of Karnataka. First aid is being given. A letter has been, official circular has been issued, and emergencies are being, now this is another question by itself. Emergencies are being, the telemanus is used to triage psychiatric emergencies. So to that extent, some things have happened. Of course, we can't resolve all that in one debate here. So the first aid is one request. The second request I have here, and I'm not sure whether these are questions, but somebody talked about early treatment. I think all of us have been talking about early treatment. Dr. Virupaksha especially was talking not only about diagnosis, but also about prognosis. Early prognosis, early treatment, which makes things much easier for families so that we don't repeatedly keep on saying burden and burden and burden. That's very common. There is no burden provided the system helps the families. And there is no burden if the families respond to the system and seek more help. So this way, it's a kind of a symbiotic relationship between the system and the family units. But whatever it is, for early treatment, if bulk of people who need treatment, right now, as you all know, only 10% of Indians or 12% of Indians getting treated. What about the rest 88%? Most of the 88%, among them, maximum live in families. So can psychiatry go to families beyond institution and community? Don't mix up community and families. Communities, the relevance, the meaning of community that WHO uses and what it was used and all the international bodies in Western countries probably is not very relevant to the demographic, socio-demographic factors coming into India now, especially urbanization. There are no communities. Let's be very clear. Family is increasingly becoming the social reality of mental illness. Whether even in villages, village families are almost getting nuclear because there are no people left. Almost everyone is migrating to urban areas. Given these changes, should we not look at psychiatry reaching families rather than stopping at community? Community at the most, how many people visit DMHP, even if Telemanus guides people to visit DMHP? Where is the guarantee they will go there? Where is the guarantee they will take medicines? Where is the guarantee families can take them there? And there are many urban DMHPs. I'm not saying urban DMHPs, the people in urban metros should not go to DMHP. I'm not saying that at all. In fact, I'm encouraging many of our middle class families to go and activate the DMHP and raise and make them understand the problems. But even then, how many people reached? Because they don't reach, there are dropouts. Because they don't reach, there is a treatment gap, a care gap or a treatment gap, whatever you say. So why can't we plan? Why can't we plan a psychiatric treatment module? Medical, I'm talking about. A medical to serve a social need. And the social reality of mental illness is happening in families on an everyday lived experience. The lived experience is not just for seminars. The lived experience is what we go through. And if psychiatry is not serving that purpose, yes, psychiatry is for a person, I understand. Psychiatry is doing exceedingly excellent work. Most of the psychiatrists treat a person and not the symptoms. Fantastic. It was one of the World Congress of Psychiatrists, so I think the statements, one of the things they did one of these years, psychiatry for person. That was for World Congress of Psychiatry. But now I'm talking about psychiatry, not just for the person, psychiatry for the family, which means a family care model in addition to institution care, in addition to community care. Even WHO has to think about it. Because it's not just in India, whether it's India, Bangladesh, Nepal, all those, even South Asian countries, urbanization is becoming a reality. So also, just like migration, you're talking about migrant labor. That is because it's social. People use the word social. And Anmol introduced me as a sociologist. Let me do some amount of sociology in this. Why don't you talk about the sociological aspect of migration? It is not just the labor, it's also the middle class migrating. It is also the industrialists migrating. Tatas and whatever you call, Birlas and Tatas, all of them migrating all over India. Is the system helping us? As Vijay said, getting an ambulance in, yes, getting an ambulance in Mumbai is about 30,000-40,000 rupees, apart from the bouncers who go with it with the batons. Is this what we are having? I'm just wondering questions. So I'm pleading to the psychiatrists. Let us take psychiatrists to the families beyond the person. Thank you so much.
Dr. Virupaksha, hearing Dr. Nirmala Srinivasan's call to action, why don't you step in? What do you have to say?
I'm sorry, I cannot help it. We are feeling that that's our experience, Dr. Virupaksha.
Yeah, you'll have to unmute yourself.
Kindly unmute.
I think what Dr. Nirmala Srinivasan said resonates with a lot of other family members. And what she also mentioned is something ideally should be done. And ideal things rarely exist, unfortunately. I'll probably, I know I'm mindful of the time that I think we have already crossed the 1 hour time. So I'll just take few minutes to just, I think this is a challenge that's going to take a really long time to equate psychiatry with the physical components, because the integration, even though we have been trying for a really long time, unfortunately has not happened to the extent that needs to be done. I'm sorry, I'm bringing out certain challenges here because only when we overcome those challenges, we will be in a situation what Dr. Nirmala Srinivasan mentioned about it. And we are all trying to work on it. And Anmol also mentioned about the psychiatrist to the population ratio. I think it is even more interesting to note that most of the psychiatrists in India are highly concentrated in tier 1 cities and to a much lower extent in tier 2 and none in rural areas. So why is this happening? That is probably a seminar of its own. And you will also not believe the amount of psychiatrists who pass, at least half of them go abroad. Okay, I think again, like I said, the challenges are there because Nishant also uh, pointed this aspect is about the human resource availability and the use of human resource and the opportunities that is available, destigmatizing the whole concept of psychiatry and mental health issues. And one small aspect that I want to focus upon is Dr. Nirmala mentioned about psychological first aid. Psychological first aid is something that is not given by mental health professionals, and which is actually important because psychological first aid is something that can be trained, anyone can be trained to provide that initial support so that the escalation of either the symptoms or the need for emergency care or need for the inpatient care is minimized. So, in that sense, the overhauling of the whole system is something necessary. We all need to put our own effort. Again, like I said, in pockets, there are systems within India which I know of providing wonderful primary care, primary prevention, where the risk management, early treatment, and all those things. Someone in the chat also mentioned about how are things in US, how are things in Europe. Well, Western countries have a very different system. There is a protocol which no one has to think. The moment there is a red flag, the whole system gets activated and it is the state's responsibility. Here, unfortunately, the health of any individual is individual's responsibility. If not, it is the family's responsibility. I think those are the lacunas. But besides that, I think we all need to make mental health conversation mainstream. The more we talk about mental health issues, mental wellness, mental illness, the more it becomes normalized, more normalized, less stigma, and people will also be able to recognize it early and then probably that is something that is a equivalent of golden hour for us. If someone recognizes that they have a problem and reach out to support and get adequate support, that is one of the important thing. There are other logistical medico legal issues. I think that is not the scope of today's conversation. Why psychiatric emergencies not being considered equivalent to physical emergencies, why there are no ambulances, why there are so many other medico legal aspects to it. I would probably request FACEMI to have another this thing of medico legal aspects of these things, which will bring in those aspects. But I think it is need of the hour. I am all for it. And in a capacity of being in a medical college and also working for two other systems, both at the national level and international level, we encourage people to get help as soon as possible. And that is my concept of golden hour. So people reach out and the systems provides that support whatever that is required in its capacity. That is the golden hour that I think about. I'll stop here. Thank you so much.
So, Dr. Virupaksha, do you think every hour in psychiatry is golden hour?
Every hour in psychiatry is golden hour, I would say. If
Okay.
if someone like for example Nishant will agree with me, if someone has an alcohol dependence and withdrawal, the first hour is a golden hour. If someone is having a panic attack, first hour is a golden hour. If someone is having depression, probably first 6 hours or 12 hours or first 1 week is a golden hour. If someone has a psychosis, probably 1 to 2 months is a golden hour. So it is variable, but I think there is no fixed
Really
this
important.
thing. Yeah.
Very, very important. Thank you. Thank you.
Dr. Nishant, yeah.
Yes,
It'd be
yes.
great to get you into the conversation.
Yes, Mr. Anmol, I would not say that I am passing the buck. It's okay. I understand what your emotions are. I definitely understand the concerns of the family member. It is, yes, as pointed out by Dr. Nirmala Srinivasan ma'am, is that yes, caregivers are under distress. There is no question about it. We need to help them. There is no question about it. And
Thank you.
as and as mentioned by Virupaksha sir, I can't agree with you more, sir. Definitely, every hour is a golden hour for every kind of a psychiatric illness. One thing, a practical thing, if I can think about for this kind of a situation, would be to what do you say, fun, to minimize, like to filter the emergencies that is available, so that we can actually concentrate about the last part of the people who are actually in need of a complete emergency kind of a thing. Because see, when we start out, if we say that okay, every patient with a severe mental illness with an acute episode, we will take them to the hospital, from the state, from the government, we will do that. I can assure you it is not possible. If we can't filter out, it is a sense, like just say, we need to address the caregivers anxiety, the distress at the beginning. If we can do through a tele consultation or anything, if we start from there, and later on, if we possible, then we can suggest them what needs to be done. And then if that is also doesn't work, and finally it is there that despite of all the effort from the mental health professional, from the family, from the, let's say, from the neighbor also, if with all the effort, if it is not possible, then I would definitely say there should be a system where we can actually help the patient as expected by the family. It is still I would say it is still a distant dream, but we can work on it. But for that, it requires a lot, as I mentioned again, the human resource that is required for it. It is the need of the hour first thing. And there is a requirement for a specialized unit, I would say, who can actually do this the basic thing. Okay, just to address the distress of the family member, just to advise them what needs to be done at the time of their what to say distress, just to hold their hands whenever they are in need, whether it is tele-based or whether it is a community support or a person who is available near them. If that can be done initially, and then from there we can start. And if that help can be provided later on, if there is a small population where which requires an acute kind of a care from a mental health professional, we can definitely think about it. I would end my suggestion with this. Thank you so much for the opportunity.
Thanks a lot, Dr. Nishant. And your point is very well taken that there's a very important need to triage in this situation to basically decide like what should constitute an actual emergency where you kick in. And I think this is uh, a family like
Mr. Anmol, you
doctors
are
like
breaking
yourself.
up.
Oh, sorry. So, sorry, I was just saying that this is actually very important that you're bringing up this idea of triage, that we need actually um, some kind of a filter. And this is why this conversation where family members, PMIs, doctors, and policymakers can come together to precisely decide what is an emergency which will be treated like a physical emergency, where basically an ambulance will be sent. If a person has not eaten for 3 weeks, does that constitute as an actual emergency? Because right now, that is not the case. I can tell you that as somebody who's lived in Delhi, I actually tried to take a family member to Ames, and I said that they have not eaten food for 3 weeks. They said, you have to bring it. No ambulance in the capital city of India was willing to take a person who had lost 30 kilograms of their weight because of diagnosis of paranoid schizophrenia. So I think we precisely fine-tuning this sense of emergency becomes very important. Absolutely, your point about us being a low resource setting is very important for us to take into account. I think that's a part of our reality that can't deny. So this is very, very useful, and I hope that we can take some of these ideas of finding mental health and physical emergencies, mental emergencies, psychiatric emergencies at parity and working towards that kind of future. So the outcomes for everyone are better. So thank you very, very much. I think we're at a mark where we can wrap this conversation. There are lots of questions that people have put out there, and I think it's we will probably actually take them at the FACEMI and FAVMI level. I think, Saraswati, we can just note down this and maybe reach out to people because they are very specific. So thank you everyone for joining, and hopefully we can take some of these insights that have come up today and kind of find ways for us to flesh out a protocol that at least meets some of the needs at this moment, if not all the needs for everyone in the future. Thank you very much.
Thank you.
Thank you, everyone.
Thank you.
Thank you, everyone.
Thank you, all the panelists. And thank you, Anmol, for being the moderator. Totally appreciate everybody's for this wonderful discussion. Thank you so much.
Thank you so much.
Thank you.